Thanks for joining, everyone. Today, this is the Selenon Ask the Expert webinar, and we're thrilled to have you here. The agenda today will be an overview. First, we're going to meet our experts. We'll introduce themselves briefly. Then we're going to go into research questions for 15 to 20 minutes, care questions following that, and then we'll have closing remarks. These are our experts for today, but I'm going to have them all introduce themselves individually. Okay, Alan, would you like to start?
Oh, okay, thank you. Hi, everybody. It's great to see you all. My name is Alan Beggs. I am a PhD molecular geneticist with a laboratory at Boston Children's Hospital and a very long-standing interest in Selenon-related myopathy, or Selenon-C-Myo, as you'll hear. There were a couple of members of my group here as well who will be introduced in a few minutes, and I look forward to chatting with you all.
Behzad?
Hi everyone, my name is Behzad Moghadaszadeh. I started working on Selenon before it was called Selenon, like many years ago, when I was a grad student in France, and found the first mutations in this gene. And afterwards, I joined the Alan Beggs group, and since then we are working on therapeutical approaches for this disease.
Pamela?
I'm sorry, I was trying to unmute and it wasn't showing up. Hi, I'm Pamela. I am a postdoc in Dr. Alan Begg's lab at Children's Hospital, and I've been working on Selenon since it's been 6 years now. So I work on therapeutic development using various models like cell and animal models.
Anna?
I am Ana Ferreiro. I'm a neuromuscular neurologist and translational scientist. I work in Paris at the Pitié-Salpêtrière hospital, both as a clinician, where I'm now the head of the neuromyology department, which is hospital, a university hospital department dedicated to neuromuscular diseases, including congenital myopathies and congenital muscular dystrophies. And I'm also the head of a research lab, and I've been working for more years than I can count, Selenon almost 30 years. Initially on identifying gene mutations in other forms of congenital myopathy after Behzad started the discovery trend. And then we moved to understanding the mechanisms that link the gene defect to the consequences in patients. And in the last years, we have been working on identifying which of these mechanisms can be corrected by drugs. This is what we call therapeutic targets. And also in developing biomarkers, that is, things that we can measure in patient blood without having to do a muscle biopsy, that allow us to develop therapeutic approaches, and also on working with muscle cells derived from patients as means to discover therapies, and drug therapies is what we're interested in.
Thank you.
And could I just editorialize that Anna and Behzad were working together in the same lab, independently, and then together made the very first discovery of the mutations in the Selenon gene as a cause of a muscle condition. It's a long history there.
Yep.
It's a long history. It really shows that you only really find what you were looking for, because we were working on the same disease side by side, sitting on the same desk for 3 years before we realized it was the same disease. Actually, it was Selenon-related myopathy.
Hence the different names of the disease.
Okay, thank you. Ester?
Hi, everyone. I'm Ester Zito. I'm a pharmacologist, and I run a lab of signal transduction in Milan at the Istituto of Ricerche Farmacologiche Mario Negri. So my lab work on Selenon, CP1-related myopathy from 2013. We are trying to understand the pathogenic mechanism of the disease. And finally, our goal is also try to develop a pharmacological approach to the disease.
Thank you. Nicol?
I'm Nicol Voermans, an adult neurologist working at Radboud UMC in Nijmegen, the Netherlands. And I have a focus on the milder end of the spectrum, so adults presenting with SELENON-Related. I've been together with the PhD students in my center running a natural history study in which we've included 11 patients with Selenon, both children and adults.
Great, thank you. Melissa?
Hey everyone, it's great to be here. I'm Melissa Wright. I'm a pediatric neuromuscular neurologist at Children's Hospital, Colorado. I also have some basic lab experience with Selenon and other neuromuscular disorders. And I have a particular interest in congenital myopathies and congenital muscular dystrophies, and in particular, Selenon.
Great, thank you. Reghan?
Hello, I'm Reghan Foley. I'm a pediatric neuromuscular specialist. I'm based at the National Institutes of Health, and our team, the Neuromuscular and Neurogenetic Disorders of Childhood group, maintains a focus on congenital muscle conditions. Not to date myself, but I think I've entered into the congenital myopathy field probably first about 20 years ago.
Great. Mimi?
Hi, I'm Mimi Boom, a pediatric pulmonologist from Stanford University, and I've been in this space for 15 years. And it's wonderful to see all the researchers here. For me as a pulmonologist, when I had my first patient with Selenon, there was nothing on Selenon. And then now through these 15 years, there's a lot more clinical data. So I am here to bring the research side to the actual clinical space and how to take care of patients and their breathing.
Awesome, thank you. Gus?
Good morning, or well, good day everywhere. I'm Gustavo Dziewczapolski, the scientific director at QCMD for the past 10 years.
And I'm Rachel Alvarez, executive director for QCMD. All right, Gus, take it away. We're going to do research first.
Yes, okay. So in the introductions, we already named the pathology different names. So one of the first questions is if one of you can clarify the evolution of the nomenclature from
I can take that.
RSMD to SEP1 to Selenon now. Okay, go ahead.
So when I first started working on this disease, it was like a group of conditions. We were not even sure if they were the same thing or not. And I inherited these few families that they had like a congenital muscular dystrophy, and the main characteristic in them was the rigid spine. So you could just call that rigid spine muscular dystrophy. And when I first found the look, it's not the gene, but the area where the gene would be located, we call that the RSMD locus. And once we found the gene, back then it was called, so the gene name was selenoprotein N, but the symbol was selen, but they didn't like it because back then with the nomenclature of the other selenoproteins, we changed that to SEP-N. And since they were not sure if there would be more, they said, okay, you should call that SEP-N1 in case there are more genes in the same family, but there wasn't none other. So we called it SEP-N1 for the longest time. And then there was a consortium on selenoproteins that decided to change the name of all selenoproteins to selen plus the letter that follows that. So for example, selenoprotein P would be Selenop, selenoprotein N would be Selenon, etc. So that's how we got from RSMD to SEP-N1 to Selenon. But it's all the same thing.
Okay, that's great to know for the community. And is there any why is important for the community knowing all these names, or?
So they don't need since it's the same thing, it really doesn't matter. So the diagnosis is based on the mutation in the gene, as we probably will discuss a little later. The changes in muscle biopsy, the pathological changes don't matter as much. They're more variable, but mutation in the gene, that's what determines the diagnosis. So whether they give you nowadays, if they get a diagnostic, I'm hoping they will just say Selenon gene, but if they say SEP-N1, it's the same thing, basically.
I think Anna could tell us a little bit about the clinical names that are attached to this. Did you want to say something, Anna?
Exactly what you mentioned, Alan, that there's another way of, nowadays, most patients get a genetic diagnosis first, so they will get right away the name of the genus, name of the disease. But for older patients, it's possible that they got a muscle biopsy first before even the gene was identified, and then have gone through all the changes in the names. And from the biopsy point of view, there were different names as well. There were 4 different names because actually from the muscle biopsies, diseases are classified depending on what we see when we look at the muscle biopsy under microscope. So some patients have that diagnosis of multi-mini-core disease because there were lesions that we call mini-cores. Other patients had a diagnosis of rigid spine muscular dystrophy because lesions that are considered dystrophic were found on their muscle biopsy. Actually, like Behzad said, it is still exactly the same disease. Only the manifestations that we see under the microscope when we look at a muscle biopsy are variable. And also depending on which muscle the biopsy was taken from and the age at which the muscle biopsy was performed, this can also introduce some variability. But whether your initial diagnosis was multi-mini-core disease, rigid spine muscular dystrophy, Mallory body-like disease, or congenital fiber type disproportion, it's still exactly the same disease. And it's all what we now call SELENON-related myopathy.
Yeah, so you can see that it can be described based on either the clinical picture, like the rigid spine, or a congenital myopathy, which just simply means muscle weakness from birth, or any of these other names that Dr. Ferreiro just mentioned, which are all related to how it looks under the microscope. But the Cure CMD has called the Selenon. This is the Selenon workshop, and that's the gene name. And so the unifying feature here is what's the single underlying cause for all of this? And that is mutations or variants, we say in genetic speak, of the Selenon gene that alter its protein, which is called selenoprotein N. And this is important because it has implications for genetic counseling, for understanding who's a carrier of the gene, from diagnosis. And as we all work to develop therapies, many of these therapies are going to be targeted specifically at either that gene or the protein or the effects of the defective protein. And so the unifying theme of everything we're going to be talking about today is how do we correct the absence of selenoprotein N, which can be caused by mutations in the Selenon gene.
Awesome, thank you. Let's go with the next question. Are there any advances in a phenotype correlation that can predict disease progression? Probably the answer is kind of short, I think, but go ahead.
Well, the answer is short, but for once it's not no. There are some correlations. Actually, what we know now, we revised, Nicol also has worked on it, but from our side, we revised together with our German colleagues a large series of 140 cases with SELENON-related myopathy in Europe. And actually, there are 2 things that emerge. One is that the very beginning of the gene, that's the right start of the gene and the part of the DNA that is just before the gene are where most mutations are localized. And actually there is a trend to have a more severe phenotype if you have 2 mutations in this region, because this usually leads to a complete absence of the protein, whereas mutations in other parts of the gene can lead to a protein that is a selenoprotein N that is there, although it's not fully functioning. So this is the first genotype-phenotype correlation. There are always exceptions, of course, but usually these are more severe cases. And well, the other thing we can say is that there is some phenotype variability in severity, even when mutations are localized in the same area of the gene, aside from the very beginning, aside from exon 1. So it means that for the other forms of the disease, there's no predictor, and mutations that are further away from the beginning of the gene, closer to the end, that lead to protein absence. We don't understand why, but they might not have such a severe impact as those that are localized in the very beginning.
I would just add to that even we have seen some families like affected siblings that present slightly different severity. So beside like the basic mutation that causes Selenon myopathy, there might be other variants in other genes that could cause like these variabilities even within the same family.
Perfect. Thank you. Is there a muscle involvement pattern specific to Selenon? And is this seen in imaging, for example, in MRIs? And the last part of the question is, can imaging be used as a biomarker?
I can take a start at this question. There are specific patterns of muscle involvement that we can see on imaging, on MRIs of patients with Selenon myopathy. There are some muscles that are really specifically affected. The sternocleidomastoid is one of the neck muscles, tends to be more affected in this neuromuscular disease than some others. The axial muscles, there are a couple of muscles in the thigh that are affected in a very specific manner. In terms of using this as a biomarker, there's a lot of interest in using muscle MRI as a biomarker in neuromuscular disease. The piece that I don't think we have just yet for Selenon is knowing what progression typically looks like on MRI over time. That's information that I think we're still trying to get. Once we're able to say, we know that the MRI changes in this particular way over time, then it becomes a better biomarker for clinical trials.
Yes,
And
and
now
I
that
can.
you mentioned, oh yeah, okay. I was going to ask if in the natural history study, are you taking MRI measurements?
Yes, we are, but the data have not been analyzed fully, so I cannot talk about that yet. But we have performed MRI at onset and then at 1.5, at 3, and at 5 years. So we will be able to say how the signal on MRI, in particular the fat fraction, will change over time. And in addition to the muscles Melissa was mentioning, the diaphragm is very thin. That's what we've seen with ultrasound. So we have used ultrasound to assess the structure of the muscles and included ultrasound of the diaphragm. And that was very, very thin, relating to the fact that there's often weakness of the respiratory muscles in patients with this myopathy.
Could I ask actually a question of Nicol? So we know that clinically, individuals often start to need respiratory support or breathing assistance, usually in late childhood or early adolescence. And so my question is, have you been able to see if the diaphragm thinness is something that develops at around that time, or is it present early in life? Or can we see any correlations and use that as a way to predict when individuals might need some breathing assistance?
There's a lot of variability there as well. And you have heard of maybe patients presenting with weakness of respiratory muscles in late childhood or teenage years. We've also seen patients who've not presented until the age of 40, or even recently someone who was above the age of 50 presenting with respiratory weakness. The fact is that it develops very, very slowly. So people tend to adapt and they can compensate for this for a long time until something else happens, for example, a respiratory tract infection. So pneumonia, for example, on top of the weakness. And then someone is getting really difficulties at night. And this we've looked at the baseline data and we'll assess the follow-up data to see how rapidly it's progressing, but it's not something which typically occurs in childhood. It's something which develops over the course of years, depending on the severity of the phenotype of the clinical features overall.
Thank you.
Maybe
Yeah, sorry,
I
go ahead.
can just add there, because as you mentioned, Nicole, you have a fantastic perspective on the mildest end of the spectrum, but there are also cases in which this respiratory failure happens in childhood, in early childhood, as soon as age 4 or 5. So it's important.
I fully agree, but then the children also have a more severe weakness in the paraspinal muscles, I think. So it's more related to the general weakness in other muscles rather than a certain age range, I think.
Yes, but it is even when they are walking and climbing stairs and respiratory studies during sleep can reveal difficulties with breathing at night as early as age 4 or 5. So this is something that needs to be looked for even if the phenotype doesn't show any respiratory difficulties at daytime.
I fully agree. And these adult patients who presented with challenges in breathing in adulthood, they had normal walking, or normal, but they were ambulant, so they were able to walk in their daily life, but still they had very thin diaphragm and very weak respiratory strength. And as a result of that, when they had a respiratory tract infection, they could not compensate anymore. And one of them played a music instrument for a long time. He played the saxophone, and I think that was some kind of inspiratory and expiratory muscle training, due to which he was able to compensate for such a long time until he had a pneumonia, and then ended up being at the emergency room and later at the intensive care. And then we found out he had this disorder. And of course, when you ask the history, then when you ask people how were you in sports in school, were you able to run, did you have any difficulties in walking the stairs, then people say, oh yes, I did. But because everything develops in these milder phenotypes, so gradually people compensate. And you're fully right that some patients present at a much earlier age. But then, as I said, when they have respiratory weakness, they will most likely also have neck flexion weakness and weakness of a rigid spine already. And I think that might be something you want to add, Anna. That's not only the weakness of the diaphragm, but also the rigidity of the cavity of the thorax. But maybe you can explain that a bit from the pediatric perspective as well.
Well, yes, the rigidity that is quite obvious when trying to flex the spine in this disease. When patients cannot typically flex their head because they have, as Melissa said before, very weak neck flexors, but they also have the same rigidity in the muscles that are between the ribs, the intercostal muscles, and this leads to a quite rigid thorax. And in order to be able to bring enough air into our thorax, into our lungs, we need to be able to expand our rib cage. And this is more difficult for these children as well. So it's the respiratory failure is a combination really of major weakness of the diaphragm, which is the main respiratory muscle, but also weakness and rigidity of other what are called accessory muscles that are not as accessory but necessary for breathing properly. And this can be targeted early up to a point from the respiratory point of view, but maybe Mimi can comment on this, because with insufflators, with respiratory physiotherapy, it can help reach as good a lung development, as good a development of the thoracic cage as possible while the children are still growing up. So there's a lot to be done before the end of growth to promote proper growth of the thoracic cage.
Yeah, that is one of the principles in respiratory care for people with chest wall weakness, is to try to maintain the expansion of the chest wall with lung volume recruitment. And I think that one of the questions later on is, what do people need to know? And that depending on the expertise and the experience of the different pulmonologists or physical medicine providers out there, they might not be aware that there are techniques that you can use to try to keep the chest wall nice and expanded. So that way that the weak diaphragm, the weak accessory muscles are at least in the right position for function, because as the chest wall becomes misshapen, that can then affect the ability of these muscles to work as well.
Thank you. We have many questions. I will need to start skipping some. But let's go to more deep in the research, more in the lab. can you give an update about the search for biomarkers for Selenon?
So shall I
Yes,
answer to that?
you can start, yeah.
So we have good news. We have good news in that in the last years, we using muscle cells that were grown from patient biopsies. We have been able to understand better what are the mechanisms that are the consequence of the gene defect and how they alter the functioning, the proper functioning of muscle cells. So one of these mechanisms affects, and this was done in collaboration with Ester, Zito's group, one of these mechanisms is the way the muscle generates energy. Muscle needs a lot of energy to function properly, and it's not very good at storing energy. So it needs to be able to generate energy very quickly and very effectively in order to be able to contract. And so this energy generation is affected when selenoprotein N is not working properly. And we wanted to understand whether there's a way we can measure this using blood samples in patients, because we cannot do, and we don't want to do a muscle biopsy to evaluate how things evolve in patients. So to cut a long story short, we are now confirming using patient blood samples that one new biomarker that measures what we call the muscle bioenergetic efficiency is significantly different in patients with other congenital myopathies that share common mechanisms with Selenon. We have found already that in ryanodine receptor congenital myopathy, for instance, which is quite close to Selenon-related myopathy, this biomarker is much, much higher than in healthy control people. And in Selenon, the trend is the same, only with Selenon patients are so exceptional that we still haven't got enough blood samples to be able to reach statistical significance. But so the study is still ongoing, but we are quite confident that we will be able to confirm that this is an interesting biomarker. And this is important for several reasons. The main reason is that when we start testing new drugs, new treatments in Selenon, but we expect also in other congenital muscle diseases in which this muscle bioenergetic efficiency is altered, like collagen 6, for instance, we can use this biomarker to measure the impact of treatments, not only to measure how patients can walk and climb stairs, but also to have this measure of how the treatment is correcting the mechanism of disease. And there are other biomarkers that we have also implementing using cultured muscle cells derived from patients that are being used now in my lab to do high throughput screening of drugs. That is, we can measure some things using patient cells that can be measured quickly, can be measured in a high number of samples, and can be measured to analyze not the way we have done it before, one drug after one drug, which takes a lot of time and resources. But now we are able to analyze hundreds of drugs at the same time. And this allowed us to run a first pilot screening of drugs, of 600 drugs that are FDA and EMA approved for use in patients, pediatric and adults. And we are finishing the analysis of this drug screening now.
Thank you. Let's jump to the next one. We have seen TUDCA mentioning research updates as a drug that help in the mouse models. And the question is, what are the next steps for advancing TUDCA or similar compounds towards clinical trials?
Esther, do you want to start with this? Since you've been involved in some of this together with Anna.
Okay, so thanks for this question. This is a complicated question. So Clearly, TUDCA is worth to be evaluated in clinical trial, but the difficulty, at least that I have in Italy, that we have very few Selenon patients, and to launch a trial with very few Selenon is very complicated, and also from statistical point of view, the analysis will be very complicated. But my point of view is that TUDCA is a safe drug. There is a long history of TUDCA is used in cholestatic disease, never show very important side effect. So I believe this is my opinion that is worth to be tried. There are some patients writing me and saying that they have some beneficial. Clearly, this need some objective parameters to be tested.
So
Any
this
advice
actually,
from the physicians about patients that want to go on themselves to try this without a formal study?
Alan, you
I
were
was
going
just
to
going to
say
say this
something.
is an important discussion to have, and I'd love it if Anna, you and Nicole, Reghan, any of the clinicians here who can give their opinions. But so, for example, I know that there are a significant number of individuals who've been trying TUDCA at home. And as Esther said, all the evidence shows that it should be safe. Certainly, you shouldn't do it without first consulting with your own personal physician. And you may get some additional advice in a few minutes. But there's a challenge from the perspective of our community wanting to safely and develop effective drugs, that when this happens, we can't measure it in a controlled way with everybody trying in the same way, and being able to compare people taking the drug to people not taking the drug. So the challenge is that this is such a rare condition, and individuals with selenone myopathy are spread out across the planet. So I'd love it if Anna, you and some of the others could talk about the challenge and what you recommend under these circumstances for people who are interested in this.
Well, it seems to me that we are in the same situation that we were 10, 15 years ago when we found the beneficial effect of N-acetylcysteine in animal and cellular models. And because N-acetylcysteine is a safe drug, over the counter, available everywhere, we started a clinical trial, but at the same time, patients started taking the drug by themselves. And well, for the clinical trial, I think it's very challenging for the reasons Esther and Alan were mentioning. There are few patients. The funding for getting this type of trial running with drugs that are already in the market and that are not, and I think this is a dire reality, but it is a reality. There's no financial interest from industry to fund this type of clinical trials, either with NAC or TUDCA. So it relies exclusively on patient-based funding and on academic physicians' drive. So it's quite challenging. We did a clinical trial that had to stop short of finishing the enrollment because of funding limitations. So we had to stop the clinical trial with NAC at 6 patients. We are now finishing really the analysis of the results. We are getting ready the publication. The good news is that it's safe. The maybe less good news is that there are some beneficial effects, but similar to what happened with NAC in ryanodine receptor-related myopathy. Either the dose was too low or the follow-up period was too short to reach indisputable beneficial effect from the statistical point of view. So I think I'm mentioning all this because I think we definitely need to work all together, and we need to bring our brains and our minds together to think of a way where we don't miss an opportunity. I think it's very important that we make sure that Number one, this time we have the good biomarkers, that we find good strategies to bring the highest number of patients together, and that we devise a strategy to make sure that we are using the good dosage of the drug. Because with NAC, I have this feeling that maybe we were a bit shy with the dosage, and that the higher dosage, well, we choose with good reasons, but maybe a higher dosage would have been more beneficial. So I think it's worthwhile trying these drugs, but I think it's particularly challenging, and it requires an international thinking that has to involve patients, because we also need to identify which are the improvements that would be most meaningful for patients and focus on those. In the clinical trial we did with NAC, we measured a lot of things, some things, and this was useful as a learning experience as well. Huh? Some of the parameters do not change at all. Some of the parameters change quite quickly. So this might be more interesting for future clinical trials. But I think it's also very important to understand which are the improvements that would be most meaningful for everyday life for patients. And in that sense, patient advocacy organizations have a major role to play.
I have
Thank
a
you.
couple of comments on this. One is just the general, any patients who are trying to figure out how to get involved and how to move things forward, the natural history studies that are happening really are key to what we call clinical trial readiness, which means we know what to expect from this disease without treatment, which lets us more successfully identify things that are changing with a particular treatment. That's so important to being able to develop a successful trial, just like Anna was talking about. And then the other key piece to developing successful clinical trials and something that's very rare, like SELENON, is collaboration, which is why you see people here from all over the world. So it's really hard to do a good clinical trial and see an effect just in one institution or even in one country to get enough patients in the trial to really see meaningful differences. We have to collaborate worldwide to make this happen. The other piece is just from the clinical standpoint, this isn't something that I have used so far in my practice because my patients haven't asked about it, and I tend to not recommend things that haven't been tested yet. But when patients come to me and ask about something that hasn't been approved yet, we sit down and we have a really thorough discussion about what do we know about this drug and other conditions? What do we know about this drug in SELENON in the research setting? What are some unknowns? Unknowns including like the best dosages, and also unknowns. Sometimes a drug interacts very differently in somebody with one particular disease than we expect. So what are potential risks of doing this? And if I feel like the patient really has a good understanding of all of those things, then I'm willing to go down that road with them to give something a try. And we set certain parameters. We say, all right, we're going to try this under these conditions. We're going to try this dose, and we're going to look for changes in these three things that we identified together that are important to you. And if we're not seeing changes in those things amount of time, then we reevaluate whether we're going to continue the treatment or not. And then also with the understanding that this is probably not something we're going to be able to get covered by insurance, and thinking through any kind of financial risks of doing the treatment as well.
Great, thank you so much. And we should move to care questions, but let me at least do one more for research that is related to gene therapies. The question was, is the AAV gene replacement therapy that's already being developed the best approach for Selenon? Better than CRISPR editing or use of ASOs? If you can comment, Alan, Behzad, on this. Thank you.
Yeah, so yes, we have been working on a gene therapy for Selenon for a number of years now. some of the early difficulties was to just fit this gene in the virus, and we were able to overcome that. And we have shown in mouse that we get a good expression of the gene. Now the difficulty is to show the efficacy of it. So one problem is that the mouse phenotype is very mild, so it's really hard to find a robust phenotype to rescue with our gene therapy. So we have been focusing on a couple of phenotypes that we saw in these mice. One would be the muscle regeneration and also muscle force. And we are in the middle of analyzing the preliminary results from this. And so far, the gene therapy doesn't seem to really completely reverse those phenotypes, the muscle regeneration and the muscle force. But we haven't looked at other phenotypes, such as like the biomarkers that Anna mentioned, or some other the expression of other genes that could be reversed. The main difficulty, I think, for AAV-based gene therapy is that Selenon needs to be expressed at the right time, at the right place. So one of our hypotheses is that it needs to be expressed in the muscle stem cells within the muscle. And those stem cells are very hard to reach with the type of virus we are using. So we are also working on developing new viruses that could be more efficient reaching those stem cells. And you mentioned the CRISPR. So CRISPR, I think Alan could comment more on that. I don't think in terms of the safety, we are there yet to really use CRISPR to reverse the mutation that we have in patients. And for ASOs, those are more like for skipping some part of the gene that's mutated. And I'm not sure if it's the adequate for Selenon.
Yeah, so CRISPR is the name for one particular type of manipulation that we generically call gene editing. And it can be used to make a specific change in the DNA from one base to another. The catch with that is that each drug, each CRISPR drug or each base editing drug, which is another method, targets just a single specific genetic change. And as we know that most individuals with Selenon myopathy have a different genetic changes from each other. So each approach by CRISPR would target just one particular type of mutation that might affect just a few people out of the entire group of individuals with Selenon myopathy. As Behzad mentioned, there are some concerns about what we call off-target effects, where this gene editing might impact some unrelated gene that hypothetically could cause cancer or other bad outcomes. And then the other major challenge right now for these approaches is efficiency. So we can do it in cells in a dish very well. We can do it in a mouse and breed that mouse to make a next generation that's corrected. But in a human being with billions of cells in their body and the need to correct a high percentage of all those muscle cells throughout the body, if we're only going to be able to change 5 or 10% of the cells, for example, to fix them, that's probably not enough to really have an impact on the disease. So as a general approach, these gene editing, there's a lot of research going on by experts in the field of genetic engineering to try to increase that efficiency. But as of today, we're not quite there yet.
Thank you. Thank you, all the researchers. I think, Rachel, we have to go to care
Yes.
questions. We have some left for research, but we'll do it.
So
in
what we'll do
another
for the questions
opportunity.
that were not answered, we'll create a document for you all to maybe contribute some brief answers, and then we'll share it with the community if that's okay with all of you. We could talk about this for 4 hours probably and still not cover all the things that we would like to talk about. So moving on to care, clinicians, key facts that we should inform our routine care providers, like our primary care providers, our pediatricians. Give me 1 or 2 things, each of the clinicians, that you think PCP should understand.
I always like to tell primary care providers, 1, to watch out for respiratory issues, as we've talked about already. And anytime a young child is complaining of difficulties with sleep or being extra sleepy during the day, that's a time we really need to be evaluating respiratory status. Another thing that I like to inform primary care doctors about that's not talked about quite as often is that kids with Selenon congenital myopathy typically don't grow at the same rate as other kids. They're oftentimes shorter, not 100% of the time. And a lot of times they have a hard time gaining weight. And sometimes that gets identified as malnutrition, even though they're following their own curve. And so I like to give primary care providers a heads up about that they may not be following the typical growth curve, but as long as they're following their own curve and showing other signs of having good nutrition, that's not something I worry about acutely. We still follow it closely, but I think about growth and nutrition a little bit differently in kids with Selenon.
My two tidbits are prevention is really important. So there's a big role for the primary care provider to advocate for vaccination to help prevent respiratory illnesses and pneumonia, and to not potentially ignore persistent coughing in a child with Selenon, where if cough can persist for 6 weeks in someone with normal muscle strength, but that's not acceptable in someone who has muscle weakness. And I really think that the primary care provider also has a role for accommodations, whether that's in the school or in the workplace, that the primary care is really helpful to write letters, whatever it is that the person may need.
Anna, Nicol?
I think I would like to stress the importance of keeping the thoracic cage elastic. So follow the recommendations of the pulmonologist in air stacking or inspiratory, expiratory muscle training, because you can most likely not train the diaphragm very much, but you can work on the elasticity of the thoracic cage, and that will help in later years. And the other thing, a way to do so is also be physically as active as possible. So adapted sports, find a way in which a child and later also an adult can be involved in a team. It can be a music team, as I mentioned before, but also an adapted sports team. And I think that will a child will benefit a lot from it, not only the skeletal muscles, but also the respiratory muscles.
Well, if I summarize it in 2 words, it would be breathing and spine. Breathing as in polysomnography studies, that means studies of breathing during sleep are necessary even if there is no sign of respiratory failure during the day. And this from very early on, because although there are late onset cases, these are more the exception than the rule. And sometimes respiratory support is needed very early, and this is actually helpful for the diaphragm in the long term. It's not bad news starting assisted ventilation. It's rather good news because it helps diaphragm recover from fatigue. And the second thing is the spine, because there's the rigidity, but there's also a tendency to develop severe scoliosis around the age of 10 years when there is rapid growth because of puberty. And scoliosis can progress and can get worse very quickly around this time. So the spine needs to be checked every 6 months around the age of 10 during the rapid growth spurt. And sometimes a brace is needed, and if a brace is needed, it has to be a special type of brace that leaves the abdomen free so that the abdomen can move front and back. Otherwise, if the abdomen is compressed, the brace can trigger a severe respiratory situation. So these 2 things are the most important, I think, to keep track of.
Just one final to add on, linking to everyone else's answers. I think wearing a spinal brace during the daytime is okay, but we've done pulmonary function testing with and without brace on. Supine or laying down pulmonary function testing with a brace on demonstrates very clearly that you should not wear a spinal brace when you are sleeping. So during the daytime, sitting up okay, do not wear a spinal brace when you are sleeping, because it will just restrict the movement of the thoracic wall. As you all said, we're going to rely on that so heavily because the diaphragm is so weak. So brace during the day, not while sleeping.
So what are some facts that providers in acute scenarios need to know? So you're entering the emergency department or urgent care. What are the things that non-expert clinicians need to know right up front?
So the very important one is that most urgent care emergency rooms, when they see a person with low oxygen, they just put the person on supplemental oxygen. And in a person with Selenon, that is not the right first approach, maybe for a couple moments, but they should be getting equipment to help support the breathing in that time. So usually low oxygen can be a sign of high CO2, which is insufficient breathing or hypoventilation. And so breathing support is necessary. And that's really important for emergency rooms to know.
So when you say breathing support, you mean BiPAP or ventilatory machine?
I like to use the word non-invasive ventilation or ventilation because BiPAP means sleep apnea, which is a different issue.
Okay. Perfect.
I think something to keep in mind, and it's good that something is written so that parents can have it on them when they have to go to the ER, is that a very reduced respiratory function in these patients is not a terminal situation. It's not an end-of-life situation, because non-experts will look at pulmonary capacity of 15, 20%, 25%, and will immediately think that it's a terminal situation. And it can be a very chronic situation that can last for years or decades, and the patients can have a very full life with that kind of situation. So it's useful to have something written that says that this is stable and that it's known as a fact of the disease, but that depending on what the patient wishes, of course, but that every measure to take care of the acute situation should be taken.
Well, and these wishes for treatment can be summarized in an advanced care plan, ACP, which is generally available, and sometimes, mostly, these are used in elderly people to limit treatment. But here you can deliberately state it's important to do these treatment in spite of the low respiratory function, because that's just part of the conditions, and people have the treatment for it at night.
Right.
And the other thing, well, to mention, if a child or adult needs to have emergency surgery, it's important that the anesthesiologist is aware of the fact that the person has a myopathy and that certain muscle relaxants and anesthetic drugs should not be used or only with lower dose. And in general, neuromuscular anesthesiologists are very much aware of it, but anesthesiologists in general need to be alerted to this. And that's also something you can carry along on a card or on an in case of emergency app on the phone.
Yeah, I love to give my patients a medical alert bracelet or necklace. There's all kinds of different medical jewelry that can have a warning about this, because this is one of those emergency things where if people don't know, they're going to use the typical anesthesia medicines, and it's very easy to avoid this if somebody knows. I also tell my patients, you don't need to know the fancy names for the things we're trying to avoid, as long as somebody can tell them, I have a muscle disease and some anesthesia medicines might be bad. Most anesthesiologists will know what that means. And so I say, just be able to tell them I have a muscle disease and that can cause problems with anesthesia, and they'll know what to do typically. And then the emergency medical information on the phone is a great place now to be able to keep information like that too.
One last question, because we're way over time. Pulmonary function testing, sleep study, when, how often, and indicators to initiate breathing support and cough assist. This is you, Mimi.
So so there is the what we as clinicians want people to do, but then there's also incorporating in your life, right? Because there's a lot of things that a person needs to balance. But really, because what can be seen on the outside in terms of walking ability is not, and even lung function is not quite tied to insufficient breathing and need for assisted ventilation, we do suggest at minimum checking your lung function and sleep study potentially every year. But the sleep studies are very burdensome, and also in some places that's actually not possible. So I do think that meeting with a respiratory specialist, whether it's your neurologist that's really specialized in it or a pulmonologist that's specialized in it, to talk about your respiratory status and to measure at least pulmonary function, and then decide when to do your sleep study. And then ideally is actually every 6 months, because even though a person can be well balanced and and compensated, as already mentioned. So things that happen in life, whether you get a really bad pneumonia or really bad illness, that can change what the respiratory status is. And so typically assisted breathing is based on sleep studies because we're looking for hypoventilation. And then in my practice, we use assisted cough based on pulmonary function testing, something called a peak-off flow, or symptoms of weak cough or a person that has low vital capacity.
So about when should we be looking at pulmonary function age-wise?
Oh, yeah, sorry. So pulmonary function, we typically start at 6 years of age, but that doesn't mean that a person may not need breathing support prior to that. Sleep studies can be done as earlier. And so as I mentioned earlier, there is variability on the phenotype, on the severity of symptoms. And so people can have breathing issues and need breathing support as young as 4 or 5. Typical is more of adolescent, and then more for the weak is in adulthood. But I think that's why follow-ups every at least 12 months minimal, 6 months ideally, helps with navigating the differences between people, right? Because every person with SELENON is a little bit different.
Can I just add one little tidbit to what Mimi said? Which, and if your child is crawling and the head is down on the ground, some parents call that snow plowing. If your child is crawling, the head is on the ground, please get a sleep study, because that degree of axial weakness indicates probably there's a need for non-invasive ventilation, and it's never too early to start non-invasive ventilation.
Okay.
Exactly. The gist here is that as soon as a child has a diagnosis of SELENON congenital myopathy, we are screening for respiratory weakness. How we screen just changes over time. We start doing like the formal pulmonary function testing. Usually we start practicing at 4 or 5 in hopes that we can get reliable testing closer to 6, but we're screening by symptoms and exam and their history, whether they're getting admitted to the hospital and things like that from the moment they're diagnosed.
Great. Okay.
Just Rachel, your question mentioned cough assist. I think cough assist is a different consideration because these patients curiously do not tend to have many respiratory infections. So what we usually do is train them and give them the machine so that they have it at hand, but they only use it when they need it, when they have an infection and they have trouble eliminating mucus. It's not something they need to use every day, but it's good that they are trained as soon as possible to use it.
So you don't necessarily recommend daily insufflation therapy?
We do daily insufflation with a different machine, 10 to 20 minutes per day until the end of growth, to promote and to support the rib cage development and lung development.
So you say a different machine, because the only machine I know to do this is cough assist.
Oh, it depends on the different national systems use different machines, but we tend to use a different insufflator machine. It can be done as well with cough assist.
Okay.
And this is as soon as possible until the end of growth.
Okay. All right. Thank you all so much. We're right on the hour. We're a little over. We'll do our best to answer the questions we didn't get to offline and share that with the community. So thank you all. It was great to see you.
Thank you.
Bye.
You.